and welcome to Grand Rounds this morning. I think many of you know me. I'm Chris Longenecker, Director of the Global Cardiovascular Health Program. I've been part of the division here since 2021. You will be seeing me again in 2 weeks when we'll be having our Global Cardiovascular Health visiting lecture, Raj Vedanthan from NYU. But today is the Sampson lecture, and I am also currently the holder of the Werner E. Sampson Endowed Professorship in Cardiology. And so it's my honor to help plan and host the Sampson lecture this year. I think many of you know Dr. Sampson, but in case you don't, he's really a treasure in our community, one of the first 3 cardiologists here in the city, together with Dr. Cobb and Dr. Bruce. And I learned last night that he practiced clinically in Seattle for 60 years. 60 years. And when I asked him last night if he had any message for the crowd this morning, he simply said, "I loved it. I loved practicing clinically." And that is indeed true, and we are all thankful for his years of service here, many of them at Swedish, but also many here at the University of Washington, where he served as the Associate Dean for Medical School Admissions, and notably really showed his dedication and enthusiasm to the students by meeting with those who did not get entry into medical school to help them think about next steps and how to make their application better. So we are truly thankful to Dr. Sampson. And so today I'll introduce our Sampson lecturer, Dr. Don Lloyd-Jones. But first I want to say this is part of a 2-part series on preventive cardiology, which is a topic I think we don't get as much of here as maybe we should. In April, we'll be having one of Dr. Lloyd-Jones' mentees, Dr. Sadia Khan from Northwestern, who is one of the architects of the PREVENT equations, along with Dr. Lloyd-Jones. And so we'll be hearing her talk about those in April. But first, Dr. Lloyd-Jones. Don did his medical training at Columbia. He then went on to MGH for medicine and cardiology, where he was with our very own Chris Patton, and taught him everything he knows. He then left Boston and went to Northwestern, where he was on faculty for many years, not many years, as I told the fellows yesterday. But then just 2 months ago, moved back to Boston, where he is the Alexander Graham Bell Professor of Medicine, Director of the Framingham Center for Population and Prevention Science, PI of the Framingham Heart Study, and Section Chief of Preventive Medicine and Epidemiology. It is fair to say that Dr. Lloyd-Jones is known as an extremely respected, highly cited researcher in our field, and we're truly honored to have him here. I think it's also important to note that he has, and I think this time I can say, many years of service to the American Heart Association, and we're grateful for that, and in particular was past president of the American Heart Association from 2021 to 2022. And so again, it is an honor to have him here today. We are really looking forward to your talk. Don Lloyd-Jones.
Chris, thank you so much for that overly kind introduction. It's really a pleasure to be here. When I got this invitation, there were many things that really thrilled me about it. One, I've really never been to UW before. I've walked around the campus, but not interacted with the great people here. And 2, it was really incredible to read about Dr. Sampson's life journey. If you have not looked into it, you should. It's incredibly inspiring. What he had to do and persevere and be resilient through to get to the United States as a young person, and then his pioneering spirit through medical education, as we heard about, but cardiology, doing the first catheterization at the hospital here in Seattle, doing the first cardioversion, as he shared with us last night, without anesthesia because they didn't know better, which he learned quickly, it sounded like. And just clearly being the bedrock of this institution. And, people like that are incredibly special. And so the opportunity to celebrate them, I think we should take every chance we get. And these kind of visiting lectureships, I think, are one of the great things about academia because they facilitate networking, new collaborations, and meeting new friends, which is really, I think, really special. So I'm incredibly grateful to Dr. Sampson, to Chris for the invitation. We had a wonderful dinner at their house last night, and it was a treat, a real treat, to get to know Dr. Sampson. So again, thank you so much. Let me also provide a disclaimer right off the bat. You were lured here under false pretenses, as Chris alluded to. I think you came because you saw that the title of the talk was going to be about risk assessment. Well, we pivoted because we found out Sadia was coming in a few weeks. So this is your free pass to leave. If you wanted to hear about risk assessment, we're actually going to talk about cardiovascular health today, another passion of mine. So again, no hurt feelings if you came and under false pretenses you feel like you should leave. So okay, so I have no disclosures or relationships with the industry, but what I want to do this morning is define this construct of cardiovascular health. Easy words to say, but when the AHA does something, they actually want to create a quantifiable scientific metric. So as you'll see, they asked a group of us to define this thing called cardiovascular health in ways that they could measure it in individuals in the population, monitor it over time, and most importantly, modify it so that we could improve people's cardiovascular health. So we'll talk about that. We'll talk about how good is it to have high cardiovascular health at different points in your life course. And then what are the implications of if we could snap our fingers and make the population have higher cardiovascular health than they currently do. Then we're going to back up and say, well, how do we achieve and maintain high cardiovascular health throughout our lifespan, if that's a good thing to do? And what are the mechanisms under the hood that are actually driving those better outcomes in people who have high cardiovascular health? And then finish up just in the last couple minutes with how you might deploy this in practice. And I'll share what we've done at Northwestern to do so. Okay, so we know, thanks to places like the Framingham Heart Study, we know what the major traditional risk factors are for cardiovascular disease. And you all can recite these in your sleep, and they've been known for decades, for sure. Led by one of my mentors at Northwestern, Dr. Jerry Stamler. Anybody know Dr. Stamler's name? Awesome, perfect. He passed away just a couple of years ago at the age of 102 because in the 1940s, he started eating a very strict low-sodium Mediterranean diet. And he lived prevention perfectly. He's really an inspiring individual as well. But he, having been one of the people who defined the major cardiovascular risk factors, then said completely, let's turn this on its head and think about those people who never develop any elevation in those risk factors. How do they do? How do they age? And let's look at that. And then that sort of body of work, which was contributed to by many people, led to AHA being interested in creating a formal definition of something called cardiovascular health in 2010. And I think the important part that I want you to take home about the concept of cardiovascular health is, we talk a lot about future risk when we're doing risk estimation, for example. And we talk about risk factors, right? And reducing risk. But we never really talk about health. Right? We don't say, what is your health status today? We say, because you have these risk factors, you are at risk for a heart attack or a stroke in the future. But we never really have a way to talk about health with our patients and what their status is today. And so that was sort of the genesis for this committee and writing group to come together. And HA pulled together, as they do, a group of just absolutely fabulous volunteers, which I had the privilege of leading. And we were charged with coming up with this new definition of cardiovascular health so that AHA could, yes, continue to try to reduce cardiovascular disease and death, stroke, and morbidity, but actually, again, have something actionable people could talk about today with regards to their cardiovascular health. So as we convened as a committee, we kind of had some ground rules that we worked out. First, health is more than just the absence of disease, right? Kind of makes sense, but it's actually a pretty important thing to think about. It's how do I feel today? There's that sort of well-being component. There's the quality of life component. And of course, there's the physiologic component of health as well. So we wanted to try to capture those things and do it in a way that was actually actionable for consumers, actionable for physicians, actionable for public health officials, so that we could actually focus in on those things that would move the needle to improve long-term cardiovascular health. And I already mentioned the 3 M's at the bottom of the slide here. Okay, so inspired by Dr. Stamler, when I was a fellow and junior faculty, I actually did research at the Framingham study. So it's kind of nice to be back in a full circle moment. So inspired by him, we took a look in Framingham at the risk factor profile, maybe the health factor profile, of people on their 50th birthday as they passed through their Framingham Heart Study examination. And what we did was we put people in 5 mutually exclusive buckets, as you see here. If they had 2 or more major risk factors on their 50th birthday, only 1 major risk factor, not quite clinically elevated, but not normal, not optimal, let's say, because we abandoned the word normal yesterday. 1 clearly within, an optimal range, but at the high level of the optimal range. And then people with truly optimal risk factor levels, total cholesterol less than 180, BMI less than 25, never smoking, blood pressure less than 120/80 at all exams, all those sorts of things, really tightly defining an optimal health status. And notice that if on your 50th birthday you had 2 or more major risk factors, the chance you would have a major atherosclerotic cardiovascular event before you die was between 50 and 70%. Pretty high, unacceptably high, one could say. Even if you had a not quite optimal risk factor level on your 50th birthday, still in the range of 30% remaining lifetime risk for major atherosclerotic cardiovascular disease. But look at these people down here, pretty special group, uncommon, but if you made it to your 50th birthday with naturally optimal risk factor levels, meaning you didn't have to be treated to get down there, basically, cardiovascular disease and atherosclerotic cardiovascular disease was quite rare. Right? So what if we could get more of the population to middle age with optimal cardiovascular risk factor levels? We might actually have a good chance to put ourselves out of business, interestingly, or largely so. And so we looked at other things as we were kind of going through this definition. And I think, again, inspired by Dr. Stamler's work, Mayor Stamper at Harvard used the Nurses' Health Study to look at lifestyles. What lifestyles as a package could contribute to this? And you see them here: non-smoking, monitor vigorous activity at least half an hour per day, lean BMI, really top 2 quintiles of a DASH-like diet score. And here's the good news, at least back then it was good news. They actually required half a glass of wine or more per day. Today we wouldn't say alcohol is so good for you, but it is a marker of higher socioeconomic status. And so good health outcomes in these women. And what they found was that if you had 3 of these healthy behaviors compared to everybody below, 57% lower risk of coronary heart disease. If you had all 5 of those healthy behaviors present at the baseline exam, 83% lower risk of coronary heart disease. So, kind of powerful way that these things synergize together to reduce our risk. And so putting all that stuff together, we defined the initial definition of ideal cardiovascular health as having optimal levels of all 7 of these metrics simultaneously at whatever stage in the life course. And you see them listed here. And my good friend Clyde Yancey, a former Sampson lecturer, defined this, he's really good at this. He came up with the term Life Simple 7, which kind of has that nice alliterative, flows off the tongue easily kind of word about it. And of course, AHA has done a nice job branding that. And so Life Simple 7, I'm not going to go through this in detail, I promise, but we take the 7 metrics of smoking, physical activity, healthy diet, healthy weight, good blood glycemia, low cholesterol levels, and blood pressure. But we actually understand that there's a full spectrum of these things. It's not just about having them good. Some people already have poor, intermediate, or ideal levels of these. And so we want, of course, to move people with poor levels of any metric into the intermediate range and ultimately, if we can, into the ideal range. And so the way to kind of quantify this is there's sort of 2 ways we've operationalized it. One, you can simply count the number of the 7 metrics that are ideal levels and get a 0 to 7 score. A little bit better to separate people out is the total cardiovascular health score, where you give 0 points for any poor metric, 1 point for any intermediate metric, 2 for any ideal metric, and you just sum up the points. And so you get a 14-point score. And I tell you that, seems a little esoteric, but I tell you that because the data I'm now going to show you are really anchored on these 7 or 14-point scores. Okay, so let's look at kind of transitioning now. What are the outcomes if you have high cardiovascular health at different points across the life course? So starting with our oldest group, this is the multi-ethnic study of atherosclerosis, coordinating center here at UW. These people were 65 years on average at enrollment, followed in this study for about 13 years of follow-up. And what you see here is this really nice log linear relationship, right? Along the x-axis, you've got that 0 to 14-point score. The higher your cardiovascular health score, the better your cardiovascular health, the lower your risk of having a cardiovascular disease event in older age. Makes sense, nice kind of proof of principle. So let's move upstream into middle age. This is the atherosclerosis risk in communities study, mean age 55 at enrollment, 20-year follow-up for cardiovascular disease. And here we've got that 7-point score, and the highest risk people with a hazard ratio of 1 are the people who have 0 optimal metrics. And notice if you have 1 compared with 0 in middle age, 36% lower risk for cardiovascular disease over the next 20 years. And while people with all 7 at ideal levels were pretty rare, 0.1% of the ERIC population, that's several hundred people who had exactly 0 events over the next 20 years. Pretty powerful, pretty stunning statement to be able to make that going from age 55 to 75, nobody had an event, a cardiovascular event. And again, you see this kind of nice dose response curve that we've seen before. Okay, so let's move upstream a little bit more. This is the Cardia study, young adults, black and white young adults, ages 18 to 30, characterizing their 14-point cardiovascular health score at baseline. Okay, so most of them are in their 20s. And what you can see is the people with high cardiovascular health, this is about 30-year follow-up. So these are very premature cardiovascular events. And in blue, if you had high cardiovascular health, pretty darn low risk of a premature cardiovascular event. Whereas in gray, if you had low cardiovascular health, a score of 0 to 7 points on the 14-point scale, then obviously a much higher event rate for premature events. So it's mattering even as young as age 18, interestingly. Okay, so let's move upstream even a little bit further. And these are data from Nori Allen at Northwestern, who's done some really wonderful work digging in on this. So she created what's called a synthetic cohort. She took multiple different cohorts and she blended them together using statistical methods to try to get more of the life course, because very few cohorts have really followed people from very early life well into middle age and after. So in doing that, she then did what's called a trajectory analysis to find out, if we look at cardiovascular health scores in these individuals over time, what patterns emerge? Like what groups of individuals, what patterns of change in cardiovascular health score do we see? And what you see is that starting as early as age 8, there is already stratification in cardiovascular health scores. People are declaring that they're in different trajectory groups by 3rd grade. Right? Pretty early, it feels like. And some of them, have maintained high cardiovascular health and keep it into midlife. Some of them have high cardiovascular health, but actually lose it pretty early and continue to lose it. And some of these kids, again, at age 8, already have poor-ing cardiovascular health, and it's only going to get worse. So then most of these cohorts, by about age 35, had started to measure carotid IMT. Very, very few events, obviously, when you're starting at age 8, but we can look at subclinical cardiovascular disease, and not surprisingly, your trajectory group membership actually was tightly associated with the thickness of your carotid IMT. And a 0.08 millimeter difference across this spectrum doesn't sound like very much, but if you put a 0.08 millimeter difference in 65-year-olds, it's at least a 2-fold difference in cardiovascular disease risk. And this is 30 years earlier than that. So I think it tells you that these people are on the fast track based on what their trajectory of cardiovascular health has been, even from early life. Okay, last time I promised, but we're going to move even further upstream. And this is a study from Northwestern called the Hyperglycemia and Adverse Pregnancy Outcomes Study, where they enrolled 10,000 mom-baby dyads during the end of the 2nd trimester of pregnancy, measured variables that we can turn into a cardiovascular health score, and then looked at birth outcomes and followed those offspring up at about age 10 to 12. And what we found was that the mom's cardiovascular health score at the end of the 2nd trimester of pregnancy was very tightly associated with the offspring's cardiovascular health score 10 to 12 years after birth. So There's a lot of shared environment here, right? There's a lot of other things that are going on, but boy, an 8-fold difference in likelihood of having high cardiovascular health, and the obverse was also true. If mom had poor cardiovascular health, she was 8 times more likely to have an offspring with poor cardiovascular health. Pretty powerful stuff. And so it makes us look at, yes, that shared environment, but also think about things like epigenetic factors and priming that may happen in the intrauterine environment, that this baby may be already starting on a more adverse health trajectory if mom's cardiovascular health wasn't so good when the baby was in utero. So kind of compelling, but certainly very powerful observation. Okay, so just to summarize, there have been over 2,000 papers that have kind of dug in on the Life Simple 7 construct and looked at what the associations are. And I'll emphasize at this point, this is not a risk score. This is a health score. It's a different thing. It is important to associate it with downstream outcomes, but it's really for us here today to be able to say, you're really healthy, great, good job, let's maintain that as long as possible, or you're not so healthy, which of these 7 metrics is really driving that adverse cardiovascular health score, and what do we need to work on? So I think that's the way we think about this, not as a risk prediction score, which would obviously have more weighted coefficients in its model and other things that we do with those. But as you can see, it's not only about cardiovascular health, this is also associated with incident cancer, end-stage renal disease, subclinical atherosclerosis, we talked about the important ones, dementia, quality of life in older age, very dependent. So your cognitive function score in cardia at age 50, very closely related to your cardiovascular health score at age 25. So maybe some of you fellows are okay, but I think pretty much everybody else is out of the bag, sorry. So, I think it really kind of talks to this cumulative exposure that Eric and I were talking about earlier to cardiovascular health in early life. Okay, so what I've shown you so far is all single measure time point of cardiovascular health and subsequent health outcomes. What about change, right? This is what we really want to know, is if I improve my cardiovascular health, does my health and do my health outcomes get better? And so these are data from some of our colleagues in Korea. They have a huge insurance database with, as you can see, 3.5 million young adults that we used in this study. And they've been examined serially over time. So baseline exam and then re-examined 3 to 5 years later, and we were able to calculate our cardiovascular health score. Unfortunately, they did not measure diet, so we only have 6 of the 7 metrics. But what you can see is if you had 0 optimal metrics, much higher event rate. If you had all 6 that were measured at optimal levels, much, much lower event rate. And you see that same kind of nice dose response curve in the hazards ratios that we saw before. But these are now young adults, mean age of 31, followed for 16 years. But again, as I said, they had a repeat exam 3 to 5 years later, 2 to 5 years later. And what you see here is a matrix. So on the vertical is the baseline cardiovascular health score, which varied from 0 to 6. On the horizontal across here is their follow-up cardiovascular health score. So people moved, right? And interestingly, we'll start with this. If you always had, at baseline to follow-up, if you always had a score of 0 or 1, those are, again, the highest risk people with a hazard ratio of 1. If you always had a score of 5 to 6, 85% lower risk of, again, quite premature cardiovascular events in these young adults. But this is the interesting group, right? Above the diagonal, these are people whose cardiovascular health score improved from baseline to follow-up. And you can see in every case, and the more it improved, the lower the risk. So I think that's helpful. But looking below the diagram, I think the diagonal, I think you also see something interesting, which is to say, if you started at 5 to 6 and ended up at 0 to 1, you were still at lower risk. So important to change, important to improve, and the earlier you do it and the more you improve, the better you will do as well. Okay, so what does all this mean if we kind of want to package this up for individual and population health? So again, led by Nori Allen at Northwestern, we have this long-standing study that Dr. Stamler started back in the late 1960s, the Chicago Heart Association study. And beginning in about the mid-1980s, we linked them to Medicare events. So they were a mean age of about 40 when we started following them. By the mid-80s, enough of them were starting to age into Medicare that Medicare data linkage which was then available, started to make sense. So we could capture events and, of course, through the National Death Index, capture causes of death as well. So we're phenotyping these people in early to middle adulthood, and then we're looking at outcomes that happen starting at age 65 because Medicare is our capture. So think about it that way, like characterize midlife, but actually look at events that happen during Medicare lifespan. And so this is the way we kind of tend to show these data, is this horizontal bar, notice, starts at age 65 when you enter Medicare. And then the horizontal bar full length represents the lifespan, how long you live after you've entered Medicare. The green part is, I think, what we all really care about, which is the health span. How long do you live without having had a cardiovascular event? And then the yellow, orange, and red represent time spent on average in this group based with either 1, 2, or 3 or more cardiovascular events. So that's time spent with morbidity. And we're characterizing people back what they looked like at age 41, essentially, right? So did they have 2 or more major risk factors, or did they have all favorable cardiovascular health score? And what you see is that if you had 2 or more major risk factors in midlife, when you entered Medicare, your health span was to 76 years. Your lifespan on average was to 84 years. So you spent about 43% of your Medicare lifespan, if that's a thing, with cardiovascular disease burden. But if back at age 41, you had optimal cardiovascular health, your health span extended to 83 years and your lifespan to 88 years. So not only extending lifespan, but extending health span. And this is a concept called compression of morbidity, right? Here's the bad news. Everybody's going to die, but you want to get sick as close as possible to the time that you die. Compress that morbidity towards the end of the lifespan. And this is one of the first demonstrations, I think, where we actually can see compression of morbidity based on real phenotypes in real people. So again, you see, yep, the lifespan extends, but the health span extends even more for people who in midlife had optimal cardiovascular health. Okay. So you're saying, well, these people are living longer, we're just going to spend more money on them in Medicare. And it turns out, even though they're living longer, we spend less money on them in Medicare because they are healthier and they are healthier later. So you can see in the cumulative costs here on the right, for people with all favorable cardiovascular health back at age 41, we spend about $75,000 less cumulatively in 2010 dollars during their Medicare lifespan than for people who had 2 or more major risk factors. And it's kind of a nice dose response. So if you want to fix Medicare costs, you got to start a lot earlier and not wait until everybody's 65. At least one way to do so. Okay, so these are other data that I think showed some nice implications of cardiovascular health and having high cardiovascular health. Data from NHANES linked to National Death Index outcomes. And what they found was that, again, characterizing people at age 50 based on high, moderate, or low cardiovascular health, what they found was that having having moderate versus low or high versus low definitely extended the lifespan of those individuals. But most of the gain in life expectancy was actually in non-cardiovascular disease deaths, right? Yep, 43% due to cardiovascular disease deaths avoided, but 57% due to other deaths avoided. So again, this is not just cardiovascular health. You are at lower risk for cancer. You're at low risk for dementia. You're at low risk for a lot of things because of that common soil of the Life Simple 7 metrics. Okay. Now, these are data from the UK Biobank saying, yeah, it's not just about cardiovascular disease. People also care about diabetes. They care about, am I going to get, cancer or dementia? If I'm living longer, having not died from a heart attack, am I just going to get cancer or dementia? And the answer is, well, everybody's going to get something, but you're going to get those at much lower rates and much later than would otherwise be the case. And you see that here in these same kind of horizontal bars with compression of morbidity and extended health span at different ages in the UK Biobank based on having high cardiovascular health. They then did something which is kind of interesting, which is they looked at, can high cardiovascular health abolish the differences we see in health outcomes across, let's say, socioeconomic strata. And so they looked at, in this case, education level, and you can see if you have high cardiovascular health but are less well educated, you have the same health span as someone who is well educated. if you both have high cardiovascular health. Likewise, a deprivation index score that's used in the UK abolishes those disparities. And likewise, for household income levels, you see the same thing. So high cardiovascular health, if people with adverse circumstances can achieve and maintain it, can abolish those disparate outcomes. Now, of course, it is harder if you're socioeconomically challenged to achieve and maintain high cardiovascular health. But if we could find ways to do that, it might sort of bend the curve. These are data from Josh Bundy, who was one of our fellows, who sort of did one of these simulation or imagination experiments and said, well, if we could snap our fingers and give high cardiovascular health to more of the population, what would the outcomes be? And if we could do that for everyone, so all adults magically suddenly have high cardiovascular health, we would avoid 2 million cardiovascular disease events every single year. Even if only 50% of people had high cardiovascular health, we'd avoid 900,000 cardiovascular events every single year. So, okay, so that's powerful. Again, that flavor of let's get people into adulthood and into midlife with higher cardiovascular health can really help us avoid events and presumably costs as well. So this has really fed into a concept that had been around for a while, but had not really been getting any traction, and that's primordial prevention, right? If people have risk factors, we must get very aggressive at controlling those risk factors once they've developed. But maybe this is all telling us that let's not let the risk factors develop in the first place, primordial prevention. And that's really the way out of this cardiovascular disease epidemic, is if we can start young, keep people healthier, don't let those age-associated increases in lipids, glycemia, blood pressure, don't let those happen. If we stunt that and keep high cardiovascular health, you can see what the outcomes are likely to be. Okay, so how might we do this? It seems like when we look across age groups, we're born with the highest cardiovascular health we're likely to have, and we only lose it as time goes on. The Doritos effect is what I'll call that. And by middle age, of course, having optimal cardiovascular health is pretty rare. So one of the questions we had was, is this pre-programmed? Do we have to lose cardiovascular health as we age, or is it potentially under our control with our health behaviors, with changing our environment as well? And so we went to our friends. At the time, I was not, I had left and was at Northwestern, but we went to our friends at the Framingham Heart Study, who have sort of the perfect design to understand the heritability of traits, because they have enrolled 3 separate cohorts of related individuals, all of whom have been examined in midlife and for whom we can calculate their cardiovascular health score. And we can see how heritable is this sort of omnibus trait of cardiovascular health. And the answer was statistically significantly heritable, but not much, 15%. So that's real, but it suggests that 85% of this trait is actually more related to our environment and our individual behaviors than it is to straight genetic inheritance. So that is indirect evidence but perhaps hopeful. So then we went back to Cardi and we said, okay, if that's true, let's look at health behaviors again and see how do people do in maintaining cardiovascular health from young adulthood to middle age if they follow, again, those 5 healthy lifestyles that we saw before. Notice that things have evolved now. So 15 years later, now it's no or low alcohol intake instead of requiring alcohol intake, but otherwise pretty similar to what we saw before. And sure enough, what you see here is that in every sex race group, if you had 0 or 1 healthy lifestyle through young adulthood, you had about a 2% chance of making it to age 50 with ideal cardiovascular health. If you followed all 5 of those healthy lifestyles through young adulthood, 50 to 70% chance of maintaining high or optimal cardiovascular health to your 50th birthday, essentially. So here's the answer, right? This is in our control. This is not a randomized controlled trial, I grant you, but pretty powerful, observational evidence that people who do the right things that we know about will maintain higher cardiovascular health. And then we know they're going to win the game, right? They're going to extend their health span, they're going to compress their morbidity, and do better than others who have not done that. Okay. So this is one of my favorite papers that's come out on this topic in the last few years. And it's been replicated in the UK Biobank almost exactly, which I think really interesting. This is done in the ERIC study, and you can see white and black participants, mean age of 54. So what they did was they calculated the cardiovascular health score, that 14-point score we've been talking about, but they also calculated the polygenic risk score developed by the UK Biobank. And they basically put people in bins. If the low polygenic risk score, meaning good genes, low risk, intermediate or high, meaning bad genes or high risk, and then the cardiovascular health score, which of course is flipped, right? Poor is bad, ideal is good. And each of these things alone did what you would expect it to do, right? If you have low polygenic risk, you have lower event rates. If you have high polygenic risk, you have higher event rates. If you have ideal cardiovascular health, you have lower event rates and so on, right? So here's the question, right? What happens when we blend these two things? Look at people with bad genes, but good lifestyle, or good genes but bad lifestyle. What's going to win? And it's not even close. So let's look at the extremes here. On the top, we have people with poor cardiovascular health, but good genes. So good genes, bad lifestyle, let's call it. And here we have people with bad genes, but good lifestyle. And the people with with bad genes, but good lifestyle, on average, lived 12 years longer. On average, 19 years longer without cardiovascular disease. And on average, 7 years less time spent with cardiovascular disease. So again, observational data, but kind of a nice proof of principle that you can trump what is, a bad hand that's been dealt to you with your genes, potentially by pursuing a better lifestyle. And we've seen this in our patients, right? Dad had a heart attack at age 42. I've been great. And, those people do a lot better on average than the people who don't follow a healthy lifestyle. So this is just kind of a nice way to quantify that benefit. I think you guys get the lessons learned. I want to make sure we leave plenty of time for questions. So I probably hit these hard enough for now. So let's get into a few minutes on mechanisms. Why does this work? Well, it seems kind of obvious, right? If you don't have risk factors, you don't tend to get disease. And that's true, but it's not universally true. So here's the MESA study. These are middle-aged and older adults. And looking at their, stratifying them by their cardiovascular health score, there's more coronary calcium in people with low cardiovascular health than there is in people with high cardiovascular health. But coronary calcium is not absent in people with high cardiovascular health. The overall CAC score is higher if you have low or poor cardiovascular health than if you have high cardiovascular health. But again, it's not zero in the people with high cardiovascular health. The IMTs are not the IMTs of young, healthy individuals. They're thick, even if you have high cardiovascular health, and they're developing left ventricular hypertrophy and some concentric remodeling as well when we look at this in more detail in MESA. So it's not that they're not aging, but they're certainly aging, I guess, vascularly aging much more slowly than the other people. And so this was kind of a fun study. This was based on that cohort that Dr. Stamler started in the late 1960s. We invited them back about 40 years later to do black blood coronary MR angiography to look at cross-sectional, in this case, cross-sectional sections of their coronary arteries to see, did the people who early on had high or low cardiovascular health have different coronary remodeling? And was that maybe one of the mechanisms that was going on here? So here you see the coronary tree, the cross sections that we took. Here's a left main coronary artery in someone who 40 years ago had a pretty poor cardiovascular health. And you can see the lumen size right there compared to the wall size, close to 1-to-1, right? There's definitely some remodeling here. And this sort of low attenuation area is actually lipid-rich plaque in this guy. You see the same kinds of phenomena in the LAD and in the RCA. And contrast that with, here's a guy who had ideal cardiovascular health 40 years ago. And you can see the lumen to wall ratio much more favorable, right? There's just not as much remodeling here in any of these arteries. It's not perfect, but it's better. And so when we kind of quantify these things, notice that people with high cardiovascular health do not have the wall thickness and the ratios of healthy young adults. They do not. They have atherosclerosis, but it's not to the extent of the people who have had longstanding exposure to poor cardiovascular health. And so, the way I think of this maybe is that we don't avoid the development of atherosclerosis. We're still being exposed to plenty of LDL cholesterol and plenty of toxins and other things that lead to atherosclerosis, but maybe qualitatively it's different. The people who have kind of long-standing exposure to poor cardiovascular health have more athero, and the people who have just sort of more benign healthy aging have more sclerosis. And so it's not as likely to trigger into events in the coronary tree or the other trees where we can see that. So a lot of ongoing work here, which hopefully we'll be able to share over time. Okay, so I've suggested to you that maybe your fixed DNA code is not the reason why we do or don't have good cardiovascular health. So what else might be going on? Well, I alluded to this earlier. Maybe it's the epigenome, right? Maybe it's our lived experience, the air we breathe, the water we drink, the food we eat, that actually is modifying not the genetic code, but our ability to express the genes that we've inherited. And so you guys are probably familiar with this, but one example of epigenetic control is methylation that can happen on the backbone of DNA, that if that occurs in regulatory elements of genes, can actually dramatically affect whether that cell can transcribe that gene at all. And this is, we think, a powerful mechanism of why identical twins with identical DNA diverge over time in their phenotypes. We all know these friends, right, who at young ages, they look absolutely identical, and as they age, they look different. Why does that happen? Their DNA hasn't changed, but the expression of their genes has changed over time. And that's because they do different things in their day-to-day life, and that changes the regulation of the genes that they're expressing. So we think of this kind of as the software, if you will, or the decorations on the Christmas tree, which is the hardware of epigenetics. You can do site-by-site DNA methylation and understand it, and I'll show you in a moment what that looks like. But one way to kind of summarize this is these epigenetic aging clocks, which are sort of molecular indicators of, are you biologically older than your stated age, or are you biologically younger than your stated age? And when we summarize that, you can see the purple line would recommend if your biologic age equals your chronological age. But we do see people who, using these epigenetic scores from DNA methylation, look to be biologically older or biologically younger than their chronological age. And when we apply those scores, what's interesting is in Cardia, again, those young adults, we looked at the cumulative cardiovascular health score from ages basically 25 to 45, year 0 to year 20, and found that that for every 1 point higher cardiovascular health score you'd had from year 0 to 20, you were about 8 months younger in your epigenetic clock. And so, 2 points would be even more, and 3 points would be even more. And then we actually replicated that almost exactly in the older Framingham population, which is kind of fun to see. Again, not proof, but maybe proof of principle, that this is a way to think about, how our environment and our behaviors get under our skin to modify our aging, and perhaps at a molecular level. When we look at specific DNA methylation sites, again, sort of a proof of principle study, we found that in looking at the relationship between cardiovascular health in young adulthood and coronary calcium in midlife, 3 methylation sites, statistically at least, mediated that association at the level of 20%. And likewise, relationship of cardiovascular health in young adulthood and left ventricular mass index in midlife, again, 3 methylation sites seem to account for 29% of the statistical relationship there. So again, please don't buy stock in these epigenetic sites. But again, I think for us, we're trying to build a case, is this potentially a mechanism by which, again, our environment gets under the skin and influences our long-term health? Okay, so we'll just finish up in the last couple minutes. Doing great. If you believe, what can you do with this? How can you use it with your patients? You, in this day and age, won't actually use LifeSimple 7, which is what I've shown you mostly this morning, because a couple of years ago, we actually had the opportunity to look at all the literature that had been developed since 2010 on LifeSimple 7 and say, what were lessons learned? How did we do this well? What could be better? What we saw was that even that 0 to 14-point score didn't really spread people out. And the way we had characterized some of the metrics wasn't fully giving credit to the differences between people and if you improved your score. And the best example I can give you is in the physical activity metric, you get 0 points if you do 0 minutes of moderate to vigorous activity per week. You get 2 points if you do 150 minutes of moderate to vigorous activity per week. And if you do anywhere between 1 and 149, you get 1 point. So those are very different people, right? So, I'm only doing 1 minute a week, but I changed my life and now I'm doing 149 minutes a week and my score didn't change. That's a little bit of a bummer, right? So we wanted to kind of reflect intra-individual change and inter-individual difference a little bit more granularly. So we changed the scoring system for the metrics and made it on a 0 to 100-point scale. And we see now that really does help separate people and get to a finer tuning of their cardiovascular health score. But notice it's no longer the alliterative Life Simple 7. We now have to alliterate with Life's Essential 8. And as many of you may know, we added sleep health as a new metric, and I had a nice conversation yesterday about this. And we thought about a lot of things. If we're going to add something here, what's the best thing to add? Everybody wants to know why not stress, and the answer is, of course, stress is important. Of course, it has physiologic effects, but those effects are hard to measure and quite variable, right? There's good stress out there, right? Purposeful stress actually is healthful, whereas stress because of segregation, whatever, is usually not healthful, right? And so it's kind of hard to quantify it, is the short answer in this day and age. So we couldn't find a good way to work stress in. But sleep kind of integrates many things, right? It's related to the other 7 things quite tightly in some cases. But it's also independent, an independent predictor of cardiovascular disease outcomes, as well as, again, can influence these other things. So we thought it was pretty well positioned and kind of pushed and prodded and ended up adding it as our 8th metric. So an extra thing to measure if you want to get the full LE8 score. But you don't have to have all of these things. You can actually use the 100-point score if you've only got 5, 6, or 7 metrics. You can still get your cardiovascular health score. So again, now we've got 4 health behaviors. You see them on top. We've got 4 health factors on the bottom, kind of the things we measure in our doctor's office. Hopefully, we're going to start measuring the top things a little bit more as well, because they do matter. And so, just from personal experience, whether my patient is young and healthy, middle-aged and has risk factors, or old and has cardiovascular disease morbidity, sending them to the website I'll show you in a second to do the things that they can work on, that they can control, and that they can see their score change as they do that, is actually turning out to be a pretty powerful way. Full anecdote here. Full disclosure, this is anecdotal, but a couple of us at Northwestern have really sort of dug in, showed the patients the website, helped them calculate their cardiovascular health score. They can go back in as themselves and then recalculate it as they change things and see how their health today is improving. And then we know that may help improve their long-term outcomes as well. So whether they have disease or not, this is still, I think, a pretty powerful way to do it. You will have to potentially measure some extra things, but we've given you some pretty simple tools to measure physical activity and diet, nicotine exposure, and sleep. We kept it pretty simple for starters, which is just average numbers of hours of sleep per night. So pretty simple questions. Here's the website. You can Google My Life Check or just Life's Essential 8, and you'll get to this point. You hit the Get Started button at the bottom there. Takes about 4.5 minutes on average to answer the questions. And then you get your cardiovascular health score out of 100, and you kind of get red light, yellow light, green light. And any of these things that you want to click on to improve eating better, losing weight, managing blood pressure, whatever, goes right through into really nice American Heart Association content on how patients can change their lifestyle to improve these things. So hopefully that's a nice tool you can play with. And I will finish here. One of the things I've learned from my many years of engagement with the American Heart Association is our voice as clinicians is incredibly powerful. It's incredibly powerful. Data gives you credibility, but stories give you power. So we know what our patients struggle with. we know the outcomes that happen because they didn't have access to healthcare, or they didn't have the ability to pay for their medications, or those things. Those stories move hearts, and the data that we have can move minds. And so please, if you are at all interested in this, like, reach out to your representatives at the local, state, or federal level. They are desperate to hear from us, I promise you. Now, that might be a little bit easier right now if you're living in a blue state, but everybody really wants, they want to serve their constituents. And health is central. It's core to everything else that we do. And in many ways, they also want to save money, right? This is a key, potentially, to helping them save money. So please let your voice be heard at all levels. You have way more power than you think you do. And so I would urge you to kind of get training, reach out. ACC and AHA have really, really good advocacy arms, and they're happy to train you on how to do this. So get involved. I will stop there. Happy to take questions. Again, so delighted to be here and so grateful for the invitation. Thank you, Chris.
Well, thank you so much. That was fabulous. Again, different than what we normally
False
get
pretenses.
here. So,
yeah.
I'll open it up for questions first.
Rob.
Great having dinner with you last night.
Thank you.
By the way, I was struck actually by one of the slides you showed. I think where it combined the bad gene score and the lifestyle score.
Yeah.
You didn't point it out, but the impact of bad genes, if you had a healthy lifestyle, was really minimal. And I guess I was struck by that because that's not, as a basic scientist, but I would have predicted.
Yeah. So you're looking at this. You're looking at the
ideal,
bar,
right? The low PRS.
Oh, so you're looking at at this stratum, and this stratum. Yeah.
There's much difference, which suggests that this concept we've had that.
Well, I don't. So I'll push back a little bit on that because I think genes obviously do matter a lot. What I think, and remember, this is middle-aged and older people.
Yeah.
So at this point, their personal behaviors and exposures are probably weighing more heavily than their genetics because their genetics kind of had their shot early, if you will. So I think, to be fair, I think, if we did this in a younger population, we might find different things, right? And that's where I think this is helpful. It's not to say genetics don't help us. It's to say, if we were to do PRSs early in life, we could maybe find the people who are going to benefit most from really focusing on healthy lifestyle as they age, right? And so I think for me, that's the take home here. It's not genetics don't matter, it's all lifestyle. It's, could we use this to personalize our approaches and say, you know what, you got dealt a bad hand with your polygenic risk score. It's going to be particularly important for you to eat a healthy diet, be active, maintain a healthy weight, because then we could maybe trump or shape, what your trajectory is going to look like. Does that make sense? Yeah.
Thank you. I'd like to follow that up with a question online from Eric Krieger, who says, how much is healthy lifestyle genetically driven?
Oh, that's a great question.
So while these are health choices, how much do genetics determine an individual's ability to engage in healthy lifestyle? Yeah,
so it's a wonderful question. Of course, we know that there are genetic propensities for health behaviors like smoking, like alcohol addiction, things like that. So those are real too. The heritability, it's imperfect, but the heritability approach to understand the amount of a trait that might be, coming through more genetic versus environmental behavior approaches does try to account for some of that, but it's not perfect. So, I think, please don't put stock in that 85% number or the 15% number of heritability. But I think it kind of tells us that, relatively speaking, we do have a lot of this in our control. And of course, there are genetic predispositions for some of the health behaviors. Absolutely. Yeah.
All right. Greg.
Yeah, thanks for such a thought-provoking talk. Really fascinating. I sort of wanted to ask a forward-looking question, ask you to look into your crystal ball for us.
Predict risk, perhaps.
Not predict risk. So you set up healthy lifestyle and genetics as a little bit of a dichotomy. But of course, we now live in a world where we can modify our, yeah, take your time. Yeah, so we now can modify our genetics. And there are products in the pipeline or even on the market that can do this with pretty infrequent injections. And of course, everyone's talking about, once ever injections. And so I just wanted you to help us think, like, should we think of this as a dichotomy, or is it going to get messier?
Okay, I think it's going to get messier. And two things I would say that I hope will kind of surround your question. One, a corollary of this is, people say, well, if I'm sitting with my patient, what do I focus on? Because it would be a mistake to say, here are 8 things, go do them all, right? And so what I do is I basically do some motivational interviewing, because it turns out, especially if you've got time, it doesn't really matter which one you pick. Like, just get them rolling and improve one of these things. And when we've looked at it, it doesn't matter which one you're improving. Again, if there's enough time to look at the outcomes, they all affect each other, and you can kind of get that virtuous cycle going. If I have a patient who's sick and I think time is short, of course I will focus on smoking. Of course I will focus on controlling their blood pressure first, because those are also triggers, right? So just to add that in, but to kind of get more on point to your question, the other part of this is, okay, if I wanted to pick a gene to alter at birth with a single injection, get in there, do the CRISPR thing, change the expression of a protein in their liver for their lifespan, what would we do that would both influence physiology and behaviors? If we could find such a gene that's a master regulator for BMI or, unhealthy adiposity, that'd be great. If I had to pick one thing today, it would be ApoB, because I think that's a sort of a master molecule, certainly for the major manifestations of cardiovascular disease that are modifiable. But I think your question's a good one, that it likely will get more messy as we have different types of therapies we can alter. But if we're going to do that, doing it at age 60 is kind of pointless. I think we would have to really go all in and say, we're going to do this early in life when it's really going to matter, and the cumulative exposure, the area under the curve of exposure, is really going to change, because that's what matters. It's time under pressure, right? So if you do this too late, it's not really going to change the course of disease.
So we're going to stick with the room. Catherine, do you have a question?
Yeah, both a comment. I mean, I think fantastic emphasis on the essential 8. I mean, I've been using it with my patients, but this website sounds like it really can enhance the patient involvement in their care. And I hope all the fellows do this in their practice going forward, regardless of subspecialty. But following up on the, it's pointless in that 60-year-old. One of the very first slides you showed that if you have patients with ideal cardiovascular health at age 50, they have very, very few events. So I guess, and this is kind of another question, you made a very compelling case for ideal cardiovascular health early in life and treating risk factors and preventing things. But if at age 50 they have ideal cardiovascular health, does it matter that they get hypertensive at age 65? Do you need to treat them? Do you need to treat their cholesterol? If they're already in that low risk group, you just let it go.
It's a great question. So the way the lifetime risk model works, we classify you once at age 50, and then we ignore what happens after. So yes, those people with optimal cardiovascular health at age 50, many of them undoubtedly did develop hypertension or other things at the age, and they still had great outcomes. I'd be hard pressed to say that we should ignore that as a clinician. And I think the way I think about it is that once a risk factor develops, the horse is out of the barn in terms of restoring low risk. We can reduce risk, but we can't ever get back to low risk. And so I think we still do want to pay attention to risk factors that develop, even in people who seem to have done it right in, as far as midlife. But I think that maybe we can think about, taking a longer time to work with lifestyle, because they've got this great underpinning, right? That means they're probably not at risk tomorrow. as you know, compared with someone who's had a long cumulative exposure. So, you know, I think it can perhaps color our approach a little bit, but you will not get me to say don't treat their hypertension.
All right, we are running out of time, but I think we'll take one more. There are some interesting questions in the chat, but Dr. Patton, I'm going to give you the last word.
Oh dear. Behavior changes.
Chris was an amazing intern, by the way.
He was.
So during my chief year, she was our most stellar intern. Easy to say, and I'm sure that surprises none of you. Yeah.
Specialist. Are we really, as physicians, the right people to be treating cardiovascular health, or would we be better off rethinking how we deliver this kind of care?
Often not, right? We're just not trained to do it well. You know, I hope that we're getting better at training medical students at motivational interviewing and helping the patient choose what they think they can accomplish, right? I hope we are. But we're not good at follow-up. We're not good at, you know, sort of coaching or cheerleading our patients, and that's time dependent and training dependent. So no, I think if we can engage other members of the health team, and if we can empower during our 20 minutes with the patient, if we can empower them to say, you know, here's some tools, maybe it's the Life Central 8 tool, maybe it's something else, but, you know, really, you know, take this, you can do this, and, you know, here's some tools to help you do it. And then, you know, hopefully some of our colleagues that are better trained for supporting patients can pick up the ball in situations when that's possible. But I don't think clinicians are particularly good at this. I agree with you.
Well, thank you. With that, I would like to present you with a small little gift from the University of Washington.
Appreciate it. Purple
Nice
and gold,
UW
love it.
chocolates and a little glassy baby from UW branded. So really, really appreciate you coming. And let's give him a round of applause.